I'm Surbhi Sidana. I'm a hematologist and associate professor at Stanford University. My research focuses on CAR T cell therapy and immunotherapies in myeloma, and I lead the CAR T cell therapy group in myeloma here at Stanford. The treatment landscape for multiple myeloma has been rapidly evolving over the last several years, right? We've had tremendous increase in immunotherapies that are out there that have resulted in unprecedented response and survival outcomes for patients with myeloma. I mean, 10 years ago, none of us could have expected that immunotherapy will explode in myeloma to the degree that it has. So we have CAR T cell therapy. It started from late line after 4 prior lines of therapy. Now it's moved to earlier line, both in clinical trials and also as standard of care. We have bispecific antibodies that came a few years ago, have completely revolutionized the treatment of late relapse refractory myeloma and are being investigated in earlier lines. And not just with one target, we have multiple targets. We have BCMA, we have GPRC5D, we have dual targeting CARs and dual targeting bispecifics, and we have very much other novel targets in development. So it's a very exciting time. So the CARTITUDE-4 clinical trial is a randomized clinical trial evaluating Cilta-cel, which is a BCMA-targeted autologous CAR T, against standard of care regimens, daratumumab, pomalidomide, dexamethasone, or POM, bortezomib, dexamethasone, in patients with relapsed myeloma after 1 to 3 prior lines of therapy. So they could be in their first relapse or up to third relapse. And patients were randomized 1:1 to either get Cilta-cel after a period of at least one cycle of bridging or get standard of care therapy. Bridging or standard of care, the physician had to choose ahead of time, so would be the same options for bridging as standard of care. So it could be DPD or PVD. And in the Cilta-cel arm, after bridging, if they were not progressing, they could get Cilta-cel, and that was it, right? It was a one-time therapy, and that's just observation and supportive care. In the standard of care arm, it was treatment until progression. And it is very interesting and very encouraging to see. We saw these results presented a couple of years ago that the Cilta-cel arm just has outstanding progression-free survival with a hazard ratio that we had not previously seen in terms of superiority for PFS. And that is what led to the approval last year in April 2024 of Cilta-cel as second-line therapy in multiple myeloma, so after 1 prior line of therapy in LEN refractory patients. So patients had to be LEN refractory. And last year, we saw the overall survival data that not only PFS, but overall survival is also improved with use of Cilta-cel over standard of care in patients with 1 to 3 prior lines of therapy. And this was presented by Dr. Murray V. Mateos at the IMS meeting in 2024. So that was outstanding to see. In terms of tolerability, most of the side effects with Cilta-cel are early on, especially in terms of infections and cytopenias, mostly in the first year. The long-term risks are, of course, small risk of second primary malignancies that we have to talk to our patients about as we discuss this novel therapy versus standard of care. But the magnitude of benefit for PFS and overall survival is just outstanding. And just to put that in context, right, this clinical trial or this CAR T was first evaluated in very late line patients in the CARTITUDE-1 clinical trial. And at the ASCO meeting earlier this year, Dr. Peter Voorhees presented data on the very long-term follow-up, so 5-year follow-up of these patients. And 1 in 3 patients receiving Cilta-cel after 6 prior lines of therapy are alive and progression-free at 5 years. And many of us are seeing this as potential functional cure in multiple myeloma. And this is in the very late line setting. Of course, in CARTITUDE-4, we don't have that 5-year data yet because the follow-up is not as mature as CARTITUDE-1, but this bodes very well for potential long-term response or functional cure in multiple myeloma. So the results of the study that I presented was the pre-specified subgroup analyses of CARTITUDE-4 at the ASCO meeting. So we've seen that PFS is better and overall survival is better in all comers and key subgroups. But here we really drilled down on subgroups of interest, which is High-risk patients defined as translocation 414, 1416, 17p, and gain 1q. How did they do? Well, they benefited from Cilta-cel both for PFS and trend towards overall survival, including the individual subgroups of 17p and 414. And we know that it's very challenging to treat these patients. We also looked at patients with extramedullary disease, and this is true extramedullary disease. And again, this subgroup benefited from Cilta-cel more than standard of care. So PFS and OS was in favor of Cilta-cel. I will say that, in the intent to treat analysis, the PFS was only 12 months. And, EMD patients, there were 21 patients. Only 13 of them actually made it to CAR-T because many of them progressed before. So they benefited much more from CAR-T than standard of care, but still there's a lot of room for improvement. And perhaps this is the population where there's additional interventions, maybe more effective bridging, maybe some consolidation or maintenance or other approaches we might want to take. But the short take-home message is that no matter which subgroup we look at, high risk versus standard risk, they all benefited. EMD group benefited. We also looked at one prior line of therapy versus second versus third because people say, well, what if I wait till second or third prior line of therapy? Actually, PFS favored each of these individual subgroups. So a third of patients were one prior line of therapy, a third were second, a third were third prior line, and each of the subgroups benefited from Cilta-cel. So there is no subgroup that, we can say from these pre-specified analysis that didn't benefit from Cilta-cel. So I think, we see this as a very effective therapy in clinical trials is performing great for progression-free survival and overall survival, and benefit is seeing in all subgroups is two things. How can we, make sure every patient who needs or wants this therapy has access to it? Because these therapies are given at specialty centers and patients often need to relocate. So how can we make sure that this is accessible to all patients? And two, this is a very powerful therapy. But of course, with every powerful therapy, there are some things we need to manage in terms of supportive care. So we need to educate our community providers and also be very on top of supportive care measures like infection prevention, infectious disease prophylaxis, vaccination, monitoring for some very rare but long-term side effects. And I think this is what we need to focus on going forward is access and better mitigating and managing toxicities.